Welcome to Quality Time, a Houston Methodist leading medicine podcast. I'm your host, Dr. Schaal, a clinician scientist and a retina specialist, and I serve as the Chief Physician Executive of Houston Methodist, located in the world-renowned Texas Medical Center. I passionately believe that quality is the heart of healthcare, and a commitment to quality is essential for every healthcare system. Join us each month as we discuss the latest advancement in quality in healthcare with clinicians, researchers, physicians, industry experts, and thought leaders who are as passionate as I am. Today, I'm delighted to welcome to the podcast Dr. Roberta Schwartz. She is the Executive Vice President of Houston Methodist Hospital and Chief Innovation Officer for Houston Methodist. She oversees all operations at the 979-bed hospital, which U.S. News & World Report named as the #1 hospital in Texas for 13 straight years. As Chief Innovation Officer, Dr. Schwartz is responsible for advancing and expanding Houston Methodist digital innovation platforms, including telemedicine, artificial intelligence, and big data. Welcome, Dr. Schwartz. May I call you Roberta?
Of course.
Roberta, welcome. I'm so delighted to have you on the show. I'm expecting to learn a lot from you. Tell us a little bit about yourself.
So I have loved being at Houston Methodist now for 24 years. Before I was here, I was in New York at Mount Sinai. I did about 5 years in consulting and more began my career in both the government and working in managed care, both in DC and in New York. I have a bachelor's from Barnard College, part of Columbia University in New York, a master's from Johns Hopkins, and my doctorate from University of Texas.
So when you were a young student, did you think that you will rise to this high rank here in Texas?
No. It was funny. I became passionate about healthcare when I was kind of 13, 14, and I was candy striping in a hospital in Pittsburgh, Pennsylvania, North Allegheny Hospital, which is now part of University of Pittsburgh, kind of as Pittsburgh has expanded. And loved it, but never wanted to be a MD physician or a nurse. I just couldn't figure out how to be part of a hospital. I learned about healthcare administration more in college and then really went after that with my master's degree and then my doctorate. So I have loved the field of healthcare administration and the ability to look at the impact that healthcare administrators can have across a very large population and very large healthcare systems. I think now, if I look back, I could say, okay, I probably could have done the MD thing and thing as your incredible profession that you attained and achieved. But I think, looking back, I still am proud and glad that I kind of went the route and have been able to impact large healthcare organizations in a very profound way.
So since you joined Houston Methodist Hospital here in Houston, what has changed? What have you seen change over the years, 24 years?
Oh, my goodness. When I joined, Houston Methodist in the Texas Medical Center was responsible for 97% of the net income for the system. There was a emergency room with a few beds in Sugar Land. Willowbrook was kind of a little bit of a larger organization, but still small. And then there was Baytown, which really was a hospital that had gotten attached to Houston Methodist, but was not the robust hospital that it is today, serving the majority of the community. It really has been a trajectory to watch not only this hospital continue to grow in the Texas Medical Center, but watch the system and really watch the growth, where now in again those 24 years, I've watched this hospital go from 97+% of the system to less than 50% of the system.
Wow,
right? And so
big
that was
change.
such a huge change of one hospital with a few outposts to, a academic medical center with a multitude of very robust, very sophisticated community hospitals that each in and of themselves are doing incredible work.
So let me ask you, this is a quality podcast. Let me ask you about the U.S. News and World Report. 13 years in a row, the hospital that you lead is number one. How do you do it?
I go back, and many people haven't necessarily seen, and you may not have seen, a number of years ago when Mark Boom kind of put a stake in the ground and said, if we're going to upseat Johns Hopkins, it's going to be on quality. It's very hard on reputation when you're a younger academic medical center to kind of have that deep 7,500-year history that you're going to have at a Mass General or a Johns Hopkins. That's very hard. So when you're doing and you're growing in terms of the way we've grown with population in the state, in the organization, you are going to focus on the quality. And as we began to basically say in each one of the domains, whether it was patient satisfaction, whether it was mortality, whether it was infection rate, we were going to drive that quality in incredible ways. You saw focus. And when we focused, we got things done. And I think that's a hallmark of this organization. We never dive into the shallow end of the pool,
I'm so glad you're giving a swimming example.
Exactly. Although diving into a shallow end of the pool would probably be a real big quality error. But when you think about it, you can't do things in a half-baked manner, right? We're going to say, once we focus, we're going after it. And then there's a nice, healthy, now beautiful competition between all of our hospitals, right? So, if you think about it, our hospitals are number 1, 2, 3, and 4. For Sugar Land Hospital to take over number 1, they have to upseat one of our other hospitals. And the nice part about it is they want to. They all, everybody encourages each other to, what did you do? I need to be out there. Your people need to come in and help me. I need to help you. Wait, why is that number low? You need to help. And that spirit of both competition and collegiality is beautiful. We used to have Larry Kellner on our board, who is amazing. And he spoke about the fact that the airlines, they never compete on quality. Right? The industry as a whole is worse off if anybody's planes go down. So when it comes to quality, they collaborate. When it comes to other areas or service or routes or other things, they can compete. They'll compete on price. They'll compete on other kinds of things, but they won't compete on quality. And I think that's the beauty of our system. And I do feel in our industry. There's a lot of work that we all help one another achieve when it comes to quality outcomes.
So you said something very important about, price and then quality. So is there a tension? We are asked to do things cheaper to reduce the cost of healthcare, and then we are asked to keep high quality and high standard. Is there a tension there? How do you solve it?
Not for me. I think one of the hard parts is in healthcare oftentimes is defining quality, right? In an airline experience, that's a little bit easier, right? I want to go out on time. I want to be comfortable. I want to land safely and get off the plane, right? And I would like to do that, in a reasonably cost manner, right? Very clear. With us, each person's on a healthcare journey that in a planned operative manner, you're coming in for a hip replacement or you broke your arm and you're getting it fixed, is very clear. You're on a journey to something broke, I'm fixing it. Oftentimes, when someone has a cancer diagnosis that may or may not be operable, may or may not be survivable, they're on a journey. And our goal is to help them with their journey. Each person's body works differently. Each person's body reacts to drugs differently. Each person will react to the chemotherapy and may go into remission or may not go into remission. And so for everybody, that quality definition is very different.
So the definition for everyone is different. However, we have standard, like U.S. News and World Report, like Vizient, like CMS. So explain more.
So for each one of those agencies, we've done the best that we can as an industry to come up with industry-wide measures that work, that standardize and allow us to look across organizations to see how well people are doing. And for us, the biggest metric that we have laser focused on is mortality. And that is during your hospitalization, for what we would expect for you, given the condition where you came in, were you less or more likely to pass during the hospitalization? So it's what we look at was what's called an observed to expected rate. And we look at observed to expected of across a multitude of metrics when we set those in the industry. And in that rate, the question is, for those people we expected to pass during their hospitalization and in U.S. News and World Report 30 days after their admission, did they pass away? And if you come to Houston Methodist, you are far less likely to pass during your hospitalization and in 30 days after your hospitalization than you are in almost every hospital across the United States and certainly almost every academic medical center in the United States, which is incredible.
Yes, that's amazing. And even, in ICUs and in critical conditions, you're less likely to pass if you're here.
Correct. I mean, we look at ICU, length of stay, mortality. We look at it across multitudes of conditions, and we are consistent, whether it's cardiac, whether it's neuro, whether it's orthopedics. We look at those and in each one of those specialties drill down to what we can do to improve your likelihood of survival. And that's a laser focus that we've had across this hospital and every one of our hospitals.
And one thing that I admire you for doing is really developing the scorecards for the chairs, where you drill these metrics and actually spell them out and review them with the chair, saying, okay, well, this is your field, your responsibility, and these are your numbers. And if there is a gap, what's the reason for the gap? And how can we help you close that gap?
One of my former mentors and former boss of mine here at Houston Methodist, Lynn Schroth, used to say, you manage what you measure. And it is very clear. If you measure it and if you hold people accountable to it and you put it in front of them, then you get focused. And when I was saying this organization is incredible about that laser focus, people cannot handle 100 measures, but they can handle 3, 5, 10 measures in different domains. And as we've done that focus on those metrics, it's the board, it's the executives, it's the physician leadership, it's the line physicians, everybody. You go straight down the line and everyone's going to have those same metrics. And that's what becomes exceedingly important.
Talk a little bit about what does it mean to have an academic hospital or, the medical center that you lead, which is an academic center, and the difference between this and a community hospital.
So, in any academic medical center, you're going to have a multitude of people who are interested in a tripartite mission. They're going to be doing everything from bench to clinical research. There are hundreds of residents, medical students, fellows
How do
running
they affect
around.
quality?
The thing that I love that faculty will tell you, and you can confirm this or not confirm it, in a conversation, is that residents and fellows keep you at the top of your game,
I agree.
right? They make you better because they're constantly asking, and so you're constantly learning. I love now having adult children. It was. Yes, did I love why is the sky blue, and why do we call this a pair of glasses, or the simple questions that are sometimes complicated to answer. But when my daughter now or my son ask very complicated questions, it causes me to go back and I may need to do some more research, or wait, where did you read that article? Or where did you see that? And the complicated things that cause us to become lifelong learners are people kind of challenging you all the time. So if you're going to teach somebody, you have to constantly be better read, more educated, more knowledgeable about those things. And I think that's what makes the faculty here just phenomenal. Not only that, but in order to do teaching, you have to have a depth and a breadth of different specializations that you don't often have in a community hospital.
What do we have here that we don't have in our community hospitals?
Transplant being probably your largest one, but in maybe our community hospitals, maybe we'll have one specialist in breast or one specialist in prostate cancer. Here, you're going to have the breadth of specialization in every different domain of cancer. Same thing in ENT. In our hospital, in our communities, we may have generalists in ENTs, and some of which have specializations. But here you're going to have, the sleep and the rhinologist and the, facial plastics, otolaryngology specialist and the voice person. And, I always describe to people when they say to me, I need an orthopedic surgeon. And I'll be like, could you tell me why? Because I just don't have orthopedic surgeons. I have the foot and ankle and the knee and the elbow and the arm and the hand and the spine. Each one have their own level of specialization. And that's when the residents and the fellows rotate. They want to rotate on each one of those services.
Yeah. Well, you talked about, the younger generation pushing us into exploring either new ways or better ways of doing things, and then keep learning and keep advancing. And one of the areas that you're responsible for is innovation. What does that mean?
So innovation is pushing our field in an incredible way. So let's back down to where we started. It was the question of, are we going to be Uber, or are we going to be Ubered, right? Uber came in from outside the industry and said, the taxi industry is not all that. I mean, it's hard to imagine now, right, our world without getting on our phones and pressing the button and ordering the Uber or the Lyft. But there was a time when you hailed the taxi. I mean, I go to New York City with my children now, and I step into the street and put out my arm, and they're like, "What are you doing?" Like, what? I mean, that's like insane, lady. And I, it's like, oh my gosh, no, this is actually how it used to be done. You used to stand on the corner and try to beat somebody for a taxi. Either that, or you went down the stairs and got on the subway, which was my favorite mode of transportation. But as you did that, now we're never going to think about it. So that was an outside player who came in and disrupted an industry. And the question really was, did we need that to happen? Or could we, who knew our field better than anybody else knew it, right? What happened if the taxi industry had stood up and said, you know what we're going to do? Put ourselves online and change the way everyone orders taxis. and you're going to be able to press the button, and we're going to have flexible pricing depending on the day and night. We're going to do that ourselves. We don't need anybody else to do it. They could have done it. They just didn't.
Yeah.
Right?
Yeah.
For us, we need to have that same movement. Your question goes back to, do you have to trade off price and quality? The answer is no. But we are a labor-heavy industry, right? Where 70% of our costs are labor.
And also expensive labor, right? Highly trained, highly skilled individuals.
Professional labor that has been subdivided into multitudes of specialties at this point, right? You go back 75 years, you had a doctor. Maybe you had a doctor and a surgeon, right? I just explained to you that I don't have, even within orthopedic surgery, I don't just have orthopedic surgeons.
You know that eyes and ears were together?
Well, all of your subspecialties used to be a section of the Department of Surgery.
Correct.
Right? I go back to a time when everyone was like, what's a hospitalist? There's a great, one of the histories of medicine books that I love, talked about the fact that there were no emergency medicine doctors, right? That was just a location where nurses were, where the doctors came down and saw their patients.
Correct. I still remember that.
So, the rise of these fields has changed the industry. Well, in the same way, innovation in our industry needs to alter the ways of doing things. And the beauty and where I have focused is not on every area of innovation. There are precision medicine and there's robotics and lots of other areas. But I've focused on the areas where digital can really refocus the business of healthcare, and in some cases, the way we provide healthcare. So if you think about it, in our healthcare system and in many healthcare systems, you used to walk up to a desk and there were a whole series of check-in people. Now, most of your check-in is done on your phone before you arrive. And when you walk up to the desk, you're going to be greeted with a series of kiosks and maybe one person to greet you. Well, we did that in the airline industry, 15, 20 years ago?
So why is medicine so behind in innovation relative to other industries? I heard a talk just a few weeks ago at Becker's where one of the leaders at Rush said, it's easier for me to go around the world, change 5 flights than to be seen and change an appointment in my doctor's office. Why is that?
So some of it is we as an industry buried our heads for a very long time about the fact that we could do this. The second one is that the regulation of healthcare, the privacy of healthcare, you don't have a presumed privacy, nor do most people care about the changing of their flight. But if they're seeing a doctor, right, there's a lot of regulation that comes along with making sure that we're doing things in a very HIPAA compliant manner. And because your healthcare information is something that is, people really are very careful about how and why and when that is shared. Because of that, the way to do things, I can't just send you out and say, hey, here's your appointment, with your cardiologist. Would you like that change? That has to be behind and in a protected manner. You don't have that with the 6 degrees of flights that you get your reminders about.
So that's why we verify who you are, just to make
Here's
sure
your date of birth. And because of that, whenever anything has 3 extra steps, people are less likely to do it.
Yes. Okay.
Right?
Good point. Tell me a little bit about the innovation that you implemented here that made a huge difference here at Houston Methodist Hospital.
So our first when I go back to our first home run, was recognizing in our care pathways that if we broke pieces of information into small chunks, that we could email or text out to you at the right time. And I would tell you, text has the most engagement of any modality. But when we broke information into small chunks and sent it out to you at the right time when you were ready to receive it, we got engagement from people, which was incredible. Like that to me,
give an example.
blew
What
my
does
mind.
that mean? Text
so
about
if
what?
we, we sent to you and said the night before you were going into surgery, now, do your CHG bath now. People, and let us know when you get it done. People were more likely to do it and tell us they were done.
And that's really directly related with quality, right? How do you prepare yourself for surgery?
If we said to you afterwards, A, are you in pain? Or B, did you walk 100 feet? We could then find out and kind of intervene with you before it got worse and you had to intervene and call us. Right? We could avoid a lot of the phone calls. I mean, people were creeped out when we would send them a note on day 6 and say, don't forget, you can't drive for 1 more week. And they would say, how did you know I was going to ask that question? And we're like, because 80 people generally call in on day 7. So we'll send it to you on day 6.
Wonderful.
Right? That was kind of our first foray into that.
Talk a little bit about virtual care.
Virtual care. We should talk about, virtual care, remote monitoring, so many different areas, but virtual care has been phenomenal, right? There was a lot of focus at the beginning on direct to consumer. I can call in and the doctor can call me. And please, I think that is a huge wave of the future. We were able to drive up those rates to almost 85+% during COVID. And sadly, they came back to under 20%. Doctors forgot that actually we were able to do a lot of things virtually. But what we are now finding in the hospital is that we can centralize a lot of care and actually beam it in over carts and TVs and service a lot of needs of people at a variety of our different hospitals. So our Clear Lake hospitals, less than 100 beds on a daily basis on their inpatient service. And our Willowbrook is 400 beds. And each one of them are going to have a different level of clinical pharmacists or neurologists or all kinds of other people. But if we can bring it to them virtually, we can standardize and equalize the amount of care that we have in each one of our hospitals, including in the academic center, right? 7 days a week. And we can bring that level to everybody in a virtual manner.
So do we do this today and where?
We do. We do telestroke, telepsych, telemedication education. We do telenursing for admissions and discharge. We do telerespiratory therapy, and it's growing. We have now put a highway. I call it the virtual highway in all of our hospitals. Every single one of our rooms have a digital way of getting in. They each have a digital camera, and they each
every
have
room.
Every room. ICU, we've had our virtual ICU for now well over 5 years. Hung the last camera. This was how I'll call out either forward thinking. I'm going to go with forward thinking rather than just dumb luck, because it had 4 years of planning before it was. But we hung our last camera in the Academic Medical Center February of 2020.
Wow, just before the pandemic.
Right. So by March, we looked like we were the smartest people that, in the universe. It was wonderful. And we were able to, because of it, right, scale up in beds. But with this digital highway we now have, where we have cameras in every room and in every ICU room, and by next month in every emergency room area, we are able to service by service add and give the ability to beam into the rooms from a central location very quickly. So if you're, call it in the OR, and someone calls from a floor and says, I really need somebody over here very quickly, right? You're in between cases, but you don't have time to run across the street and 3 buildings over. We can beam you into the room from your phone and have you take a look at the issue we're concerned about very quickly. You give us advice, we get going, right? Without you walking across the street and spending a half an hour going back and forth, and you can keep going with your next case.
So this is incredible. And people in healthcare specifically are used to the way things are, and it's very difficult to accept change. How do you lead change?
So let's take our telehospitalist service that was brought on board. The concept behind it, that we would bring a telehospitalist service at 6 p.m. at night and have them do the admission orders, was kind of one of those like, I don't know about that. That's the first thing you get. I'm not sure. I don't know if that's going to work. And then we started kind of producing the data. Here's how many just tuck-in orders we get. Here's how long it takes because there are so many admissions between 3 p.m. and 10 p.m. at night. Here's how long it's taking for those patients to get a full admission order set. And when we started showing the data and said, we could help, let's try it. Let's actually use our current doctors that are willing to do some extra shifts and demonstrate that we can actually, we're not going to take your money. We're not, we're just trying to do a better job here. And people stepped back and said, the current hospitalist groups that are using it are grinning from ear to ear. They're sleeping. They're able to concentrate in the mornings more. They are spending their time on the patients who are already in the hospital that need their support. They're saying the orders are amazing. They're coming to us. They understand what we need. They're working with us. They're doing a great job. And so that is now expanding from our first 2 groups to now the next 3 groups. And everyone is saying, this is helping us.
So you're starting small with a small group, showing the value, and then you're spreading. You don't start like all in across all the system.
Yeah, but you always start with skeptics. We assume in innovation that we are going in a skeptical manner. And therefore, we have to go in bullish, right? It's going to work. This is going to help you. We are going for it. We're jumping into that deep end of the pool the way we do in that laser focus, and we're gonna do it. And then if we have to back up, we back up. People will always say to us, if it doesn't work, will you remove it? Absolutely. Why would I want to keep going with something that doesn't work or that like paying for something that isn't? But when we went forward to put cameras in the room, we did not go in putting 1 unit and testing it with 40 patients and then waiting till, waiting for Godot until, we basically had the capital to expand it. We said, this is part of our strategic focus. We believe in this as a way to move forward. We're putting those cameras in the room. And each day and each week, somebody else approaches us and said, can I get on those cameras? Wait, when's my turn? Hold on. Wait, no, I can use them. We have so many people lined up. And we can only roll so many people onto the cameras each week.
So to your point, the Uber example that you gave, maybe in 5 years, people would have a hard time to imagine how you can take care of patients without a camera in the room, without a virtual option.
Oh, I do believe in 5+ years, there will be no hospital can imagine not going down that road to put in that infrastructure.
So now I'm going to use your favorite word that I know, favorite expression that I know you're going to like, which is artificial intelligence, AI. How are we using AI now at Houston Methodist?
So, the reason I hate the term, and we always say this, is because it's so genericized at this point. It's hard to, it's almost too general. So it's very hard to nail down what we're talking about. But if you take the term of using an algorithm to help us better manage our care, kind of what that artificial intelligence is. There are so many different ways now where we are using it. First of all, it's built into so many things we're doing. From the simplistic, you start on your phones typing a sentence and it finishes it for you, right? That's kind of background algorithms that are running. We began in our virtual ICU, how we prioritize those nurses in the virtual ICU are watching 40 to 60 patients, but they're not watching in detail 40 to 60 patients. The algorithms are defining which are the 10 top patients that they need to focus on and which one is concerning at that moment. And we're doing the same thing with vital sign monitoring on every single acute care patient now. We have vital sign monitoring going on. If you look at an algorithm of yesterday, it was working off of, let's take sepsis. It was working off of vital signs that we took every 4 hours. Now, we're putting those vital signs in the system every hour. An algorithm is going to be far more exacting when you have data going in every minute or every hour.
So you can predict deterioration, right?
Correct. So we now are, our CERT teams are often actually sent to the bedside from the virtual monitoring center. So they're watching someone, calling the nurses. They call the CERT team and say, you know what, can you go out and check on this patient?
Mm-hmm. And
We almost
lives
call
were
them
saved, right? I
pre-certs.
know you gave several examples where really we saved life by predicting deterioration and actually preventing mortality.
Yeah, and those patients who go to a higher level of care, we're seeing a reduced mortality if we've intervened because of our algorithms, because of what they're seeing in the virtual monitoring center.
So AI excites you even though you hate the expression.
Yeah. Oh, and I don't hate the concept, right? I hate the fact of when someone says to me, oh, just AI is changing things. I always say to them, which AI? Can we discuss which one? Because everyone immediately today goes to the generative AI that physicians are actually, it's my favorite one. I'm like, okay, which one are we talking about? And they'll immediately go to the ones where physicians go into a room with a patient, start having a conversation, and it generates the notes.
Yes, ambient listening.
Right. That's fantastic. Ambient listening, generative AI. That is fantastic. That is a use case. But so is the one where in the computers now, if a physician pulls up, I do predictive modeling of those patients who are going to be readmitted or have a high rate of mortality. We are looking at those patients who have high rates of falls. Those are all different use cases for artificial intelligence. I often just, when someone says it to me, I'm like, okay, could you give me a little bit more before we start having a conversation?
Fantastic. There's so much to talk to you about, but I have to ask you, out of this last 24 years, what has made the biggest change, like the switch that you led through many, many changes in operations, in mindsets, in culture? What is the one thing here at Houston Methodist that you can say this was before that whatever thing, and this is after, and it's completely different?
There was a moment of time where Methodist had to think about what we were going to be when we grew up, right? I mean, there were changes that happened in the marketplace, and we had to take all of our poker chips and say we're all in. And this institution and the board of directors had the forethought and the dedication to say we are moving forward as an academic medical center that was going to be dedicated to being the best. There was no reason that the southern part of the United States did not have an honor roll U.S. News hospital, and that we were going to become that place and take over a top spot in the country.
So that came all the way from the board.
Straight up. Everyone had to say, what are we going to be?
Mm-hmm.
And I remember, I say this in one of our documentaries, but I remember sitting down with, at the time, the chair of our board, and I happened to be in one of the meetings, and we were talking about the center, and he's Mr. Bookout turned 100, so he's not young, but he's still incredible. And talking to him is just, it always has been and always will be a pleasure. And he said, I don't want you to talk to me about what we're going to be in 5 years. Talk to me about what we're going to be in 75 years.
Wow.
And to have a group of directors and a group of executives who said, we're in it for not the short term, we're in it for the very long term. That was a defining moment for me. And I will forever be both grateful and in awe of that moment in time.
Wonderful. The last question that I'm going to ask you is a question that I ask all my guests, which is, what does quality mean to you?
Quality means that I can always be better. That it's never in healthcare, there's no such thing as perfection unless we have eliminated all disease. And we do an incredible job of the way our industry treats people. And there's quality makes me better every single day because it reminds me that I'm never good enough.
Fantastic, inspiring. Thank you so much, Roberta, for being here with us.
Thank you for having me.
And thank you for listening. Quality Time is part of Houston Methodist Leading Medicine series of physician-led podcasts. So that you never miss an episode, subscribe to Quality Time. New episodes will download to your podcast device. If you enjoyed our conversation today, please consider rating this episode and sharing it with your colleagues. I appreciate your support. Thank you. And until next time, I am always listening.